is it's kind of like you guys ever been in a laminoplasty for a cervical laminoplasty? So basically, cervical laminoplasties are done specifically for stenosis. So when you have central stenosis type, all they do basically is they take a laminoplasty is they cut down the lamina on one side of the spinal column, and they open the lamina and they put wedges at each level. So it's usually like a C3 to C7, and they'll put wedge every level. And all that does is basically opens the canal. That's all they're doing here is they're opening the pressure. Because you just have all this pressure that's causing hydrocephalus and other nasty things. They just want to, but it's a dangerous procedure because you're right at the base of the brain. So we'll do bears, we'll do SSEPs. Maybe we'll do lower cranial nerves, depending on what they do. I mean, they really shouldn't get into the cranial nerves because of the cerebellar tonsils here and your cerebellum's here. But you never know, so it doesn't hurt to do, depending on the surgeon, cranial nerve 12. And, this is kind of showing you, I would even do motors on these cases because you're really at the upper spinal cord too. But this is kind of showing you, here's 11. So this is really the area where they're working in. Here's C1 here. And here's the spinal cord. So you can see 11, 10, 9, 12. This is C1 right here. C1 nerve root, which we can't monitor. But basically, you want to monitor SCPs, I would do MEPs, bears, and lower cranial nerve EMG. Now, tumors in the CPA, the cerebellum pontine angle, are the most common neoplasms in the posterior fossa. And most CPA tumors are benign, like 85%. So if you're in the CPA, it's going to be a posterior fossa approach. And again, it's going to be the same thing as like doing an acoustic neuroma, because that's a CPA tumor. There's other tumors that can be in the CPA that aren't acoustic neuromas, but your acoustic neuroma is the most common CPA tumor. So, but you're going to monitor all these the same way, depending on the where the tumor is and how their approach is going to be. You're going to monitor with the same modalities as you would an acoustic neuroma. So this is a meningioma of the CPA. So here's the tumor. And then here is the 7-8 complex here, tumor. Retractors on the cerebellum here. So as they're taking out the tumor, cranial nerve 5 is exposed now. So here's 7-8 still, 5. So you have to monitor all of this. Taking out tumor, and here's cranial nerve 5 was sitting right underneath this tumor. So if you're not monitoring it, they can take it, and avulse it. Then the patient wakes up with a fifth nerve injury. Another type of remember we're talking about this is all skull base type procedure so far we've been talking about is a third ventriculostomy for the removal of a mass in the third ventricle. This is usually done endoscopically. And surgical procedure where an opening is created on the floor of the third ventricle using an endoscope. It allows cerebral spinal fluid to flow directly into the basal cisterns, shortcutting any obstruction. And basically, it's almost an alternative to a shunt when there's a mass and they want to get that mass out. The problem is that the patient can have a subarachnoid hemorrhage of the basilar artery. So this was a case that I think I went over this with you guys a few months back, but we actually did this case. This was the patient's 40-year-old female with a height of 5'8" and a weight of 133. Patient was asymptomatic. They were just had some episodes of dizziness for 1 month, and they presented with a colloid cyst in the third ventricle, leading to hydrocephalus. They didn't have any relevant medical or surgical history, and the patient was also pregnant in her first trimester. So modalities that we use is, well, the approach is basically through the forehead to the third ventricle. If the most common injury is basilar infarction, what do you think we should monitor in a case like this? What's that? SSEPs? Bears. So we did bears and SSEPs in this case, and we might have done motors too. But basically, you want to do bears because the basilar artery perfuses the brainstem. So you want to watch your bears. The approach was a right frontal approach. He's just showing you the waveforms that don't come out on the screen for some reason. And we did MEPs and we did EEG. And then we did bears. Is it me or you guys can't see that at all, right? That is lame. I don't know why it's not coming up. So this is just, our bear setup. And again, since they went through the anterior fossa here, we weren't worried about having to set up our bears, if they're going, I make this point when you go posterior fossa approach, you have to make sure that tape's not in the way. That tape is in the way, it's getting ripped out. So that's skull-based stuff. We're going to talk a little bit about EMG of cranial nerves, the actual science behind the EMG of cranial nerves. Basically, you're going to do two types of EMGs, right? You're going to do triggered EMG, and you're going to do spontaneous EMG. These are the filter settings that are typically used. Low frequency, a bandwidth of 10 hertz to 1.5 or 2,000, sensitivity of 100 microvolts per division, and then a time base of 200 milliseconds per division. For triggered EMG, you're going to do, repetitive pulses, rep rates, 1.7, 1.9, 2.7, 2.1, pulse duration of, 0.20 milliseconds or 200 microseconds. Your frequency filter should be the same, but your time base is going to be anywhere from 5 milliseconds per division to possibly 1 or 2 milliseconds per division, depending on what you're doing. So if you're doing, for example, seventh nerve, I like it in the middle of my screen, so I might do 2 milliseconds per division because it comes in around 7 milliseconds. Fifth nerve comes around 5 milliseconds. So if you're doing 5 milliseconds per division, you might not see that fifth nerve. It might be engulfed in your artifact, in your stim artifact. So just keep that in mind. This is showing 2 millisecond per division. And you can see you get a good cranial nerve 7 and cranial nerve 5 responses. A lot of times, unlike lumbar triggered EMGs, these tend to be temporally dispersed. Recurrent laryngeal nerve tends to be temporally dispersed. It's more a rounded waveform. You can see it here. These are triggered EMGs of cranial nerves of the extraocular, medial rectus, superior oblique, lateral rectus, and then here's a facial nerve. So basically, when you stimulate cranial nerves, you don't want to exceed 4 milliamps. You don't need to exceed 4 milliamps. Cranial nerve 7, the CMAP occurs around 7 milliseconds, and cranial nerve 5 around 5 milliseconds, which is a good way to figure out if you're stimulating the right nerve, especially if you're using the masseter. You can know where you're, which one you're actually stimulating. And what you have to remember when you're stimulating cranial nerves, you're monitoring cranial nerves, you're monitoring at nerve root level. So you're monitoring ipsilateral activity. Damage is going to happen ipsilaterally. So there's no crossover here. So direct nerve stimulation is triggered EMG directly on a nerve. Right? We utilize it in skull-based surgery, spinal cord tumors, tether cord releases, ENT surgeries, and peripheral nerve surgeries. I'm going to keep my focus on the skull-based stuff. It's used to map and locate cranial nerves. Remember, mapping and monitoring are two different things. Mapping, locate structures. Monitoring, make sure the integrity of the structure is not harmed. So when you're stimulating, you're mostly mapping. But it could also be used as a functional test to make sure that integrity is still intact. So sometimes what the surgeon will do will stimulate, find the 7th nerve, and then stimulate it consistently. If he knows where it is and he's away from it, he might stimulate it consistently throughout the procedure to make sure no damage has occurred. 2 different methods you can use to stimulate. You can use a monopolar stimulus or a bipolar stimulus. In a monopolar, the probe is a negative, reference is placed in a nearby silent area. Probe can be a ball tip, it can be a flush tip, it's whatever the surgeon's preference is. The thing about monopolars are that the current spreads robust and it goes everywhere. And it's highly sensitive as opposed to highly specific. It'll tell you that the nerve is there, but it won't tell you that you're directly on the nerve. That's the thing about monopolar, and I'm going to show you why in a second. But this is basically what the stimulus actually, the stimulus field looks like. This is it. This is what happens in a monopolar. And this is showing you, I think, at maybe 10 milliamps. This is from a lumbar situation. But this is showing you, so imagine that field gets exponentially bigger as you increase the stimulus intensity. Just keep that in mind. We start looking at bipolar. The active and the reference are together, so your current spread is much less. And the stimulus is between the tips. And this is a true bipolar. Bipolar probes that are used in peripheral nerve surgery tend to be have a larger spread. The ones we use in cranial nerve surgery are smaller spread. Sometimes even smaller than that. Sometimes they're concentric, which I'm going to get into. But basically, this is where the monopolar, right, had that big current around it. The current only goes between the 2 tips on a bipolar, which is what makes it specific. But basically, the bipolar, basically goes between a positive and a negative, and the current is between that positive and negative. It doesn't really go outside of that area. This is just showing you the different bipolar. So this is the true bipolar that I use, and then here's a concentric. I have a closer version to show you, but the concentric looks like a monopolar, but it's a concentric. And if you look closely, you can see that there is basically this anode, and then the cathode's on the inside here. And here's a close-up of one. So basically, this is all anode on the outside, and that's the cathode on the inside. So the current spread, this is actually the current. So this is just showing you different versions of a concentric bipolar. But basically, the current's coming out of the cathode, right, the negative, and it's going to the anode. That's why it's so specific. It doesn't have this big, large, robust, which means that if you're using a concentric bipolar and you're not on the nerve, you're not going to activate the nerve. If you're using a monopolar, you're not on the nerve, you could potentially activate the nerve. And this just shows you. So here's the monopolar, right? So imagine if my nerve is here, 7th nerve is right here, but he's stimulating tissue down here, what's happening? I'm getting a response, right? Concentric, my nerve is here, and he's stimulating, no response. Same thing here. Nerve is here, stimulating with bipolar, no response. So just keep that in mind. And it's really surgeon preference to what he wants, and it depends on what he needs it for. Some surgeons just want to know the nerve is in the area. They're fine with a monopolar, go down, okay, I know it's there, we're fine, good. Some surgeons, especially if you have a really intricate tumor, really want to map it out. And then you'll start with monopolar, and then you'll go to bipolar. So it's really surgeon preference and really what they want it for. That's what you have to take into account. It's not, not one isn't better than the other, it's just, they do different things. So you have to keep that in mind.
Intradural spinal cord tumor, would you prefer a bipolar? Because I do. Because what happens, I see too much spread and, can't be site specific with the surgeon.
With a monopolar?
I'll try to talk you into it, yeah.
Right, with a monopolar. I do the same thing. So we just did 2 of these. We did an intradural tumor not too long ago, and the surgeon told me to bring every probe I had. and he wanted all these like special probes, and he ended up just using a monopolar. But it wasn't specific. I think he just wanted to make sure there was integrity when he went in. So he basically what he did was they weren't sure if there was anything inside the dura. There was like a tumor, but they weren't sure if it was intradural, so they opened it. They do a durotomy, they open it, and they go in and they stimulate around. And I think only thing he was looking for was there tumor inside there? And if he stimulates and we got an activity, he figured there wasn't. So I think you can be more specific with a bipolar, but he didn't want to hear it that day. A couple weeks later, we do a same thing, an intramedullary tumor, and we open up the cord, and my partner did the case, and he told the surgeon we should really use bipolar, and the surgeon listened to him, and we did the bipolar, and it worked just fine. He got the response you want, super specific, but it all depends on the surgeon and what they want and what they were looking for. But you're absolutely right. Concentric. We go for concentrics more than we do regular bipolars because the concentric is just you don't have to worry about the two tips, and the surgeons aren't really comfortable with the whole bipolar thing. They like the monopolar, and the concentric kind of has that look and feel, and it's just more specific. There's nothing wrong. You can use regular bipolar, but concentrics just if you're in a spinal cord or you're in the cranium and you're stimulating with a monopolar, you're more chance to get current spread and more chance to activate other areas. Where with a bipolar, this is it. That's your current spread. So if you're either on the nerve or you're not on the nerve, that's the nice thing about bipolars. But they have their place. Now these are cool. We just started using these. These are actually dissecting instruments that stimulate as they dissect. So basically, this is like a ring curette, and there's like a sharp here. I don't really know what that's for. And this is an elevator. And basically, these are monopolar. So you keep it at a low current. But the surgeon I work with actually likes these because they plug into our machine, and we keep a constant current as he's digging out the tumor. Specifically with this ring, he actually digs out the tumor with that. It's an instrument. So we got this specifically for one of our surgeons for this intramedullary tumor, but he also said he likes it for his posterior fossas, which is why I wanted to show you guys. It's a cool idea. Basically, as he's taking out like an acoustic, you leave the stim on at 0.5, 1 milliamp, and you just tell him that there's activity. And I think really it's for continuity of structures. It's not going to be super specific because it's a monopolar, but it's for continuity. He knows that as he's going, he's getting responses, all of a sudden he gets no responses, and he's doing the same thing. He knows something's happened, or the response has changed. He can immediately. It's just a real-time monitoring of stimulus, which is pretty cool. And it plugs into our machines. Basically they come in these sterile packs. What really annoyed us and annoyed our surgeon was all he wants is this ring. And you can't get the ring by itself. You have to buy the 3-pack, which is lame because if he doesn't use the other two, these are sterilely packed together. So, but it is what it is. They're not super expensive, and you know what? It's no, they're not reusable. They come sterilely packed and they're all together. So it's kind of like a sham on the side of the instrumentation company making it, but it is what it is. So cranial nerve 5 and 7 are the most commonly stimulated nerves, but you can stimulate all other motor innervated cranial nerves. And again, technique, sterile monopolar probe to find the nerves, and then a bipolar or concentric bipolar to be more specific if that's what the surgeon wants. So here's some considerations. The patient can't be paralyzed. They should have 4 out of 4 twitches. Stimulation greater than 4 milliamps is not needed and not recommended. If you're not getting activity up to 4 milliamps, you're either not on the nerve is damaged, or the patient has paralysis on board. A healthy nerve depolarizes between 0.5 and 2 milliamps. If you stimulate greater than 4 milliamps, you can damage the nerve. And that is a question on the CNIM for those of you that are taking it. So just keep that in mind. You don't want to go above, and you really want to go like in 0.5, milliamp increments. And I think, I always forget, I always, day of, I figure it out, but it's either page up or page down on the Cadwells, or the arrow. I think the arrow is 1 milliamps, right? And the page up is 0.5 milliamp increments. So just keep that in mind when you're doing these. You don't want to scroll up, because if you use the turn knob, you can jack up, inadvertently jack up your stimulus. Here's a quick case study of a skull base. So just showing you tongue, soft palate, traps, a left trap, right trap, and cricothyroid. So this is like a lower cranial nerves, right? Basically 10 or 9 through 12. So look at the timing here. This is pre-incision. Some noise in the channels, but it is what it is. But it's pre-incision, 8:59 a.m. We've added the masseter to this, so we're doing 5, 9 through 12. I don't know why we weren't doing 7 in this case. I don't remember. This was many, many years ago. But basically, it's 11:11 now. So we started at 8:59. It's 11:11. We're resecting the tumor, 13:46. 16:39. So now we went from 1 o'clock to 4 o'clock. We're still resecting the tumor. 16:44. This is the right trap and cricothyroid. So this is a right-sided approach. And obviously you can see EMG activity. 17:35, so it's 5:35 p.m. now. And we still have this persistent EMG activity from the right trap. This is 10-hour surgery. The EMG began at 16:44 and lasted for 3 hours, did not subside through closure. What type of deficit do you think this patient woke up with? A, B, C, or D? Who says A? Who says B? 100% correct. Patient woke up with a wing scapula. And this was one of those surgeries where we told the surgeon at 13:44, we're getting activity from the trap. I didn't do anything. I didn't do anything. And then, 3 hours later, he came up to us and goes, yeah, I went through the nerve. So, but yeah, patient woke up with a wing scapula. Any questions? So what time? Do we have to take a break now?
It's lunchtime, if you're ready.
Let's do it because I'm done with cranial nerves and EMG. So we're going to get into, after lunch, we'll get into some supertentorial stuff. Any questions on stimulus, guys?
I have a question.
Hey,
I saw a tripolar stimulation. Do you know what they use for?
Tripolar stimulators are for peripheral nerve surgeries.
Yes.
And basically, you can do, when you stimulate, you have one anode and you have 2 cathodes. But you're not doing actual, it's really, the way it's set up is really bipolar stimulation. You can just choose between the 2 points. So you can do an antidromic or an orthodromic stimulus.
To fill the leads maybe?
Yeah.
Because they are 3 and one of them is a little bit further?
It depends on who you buy it from. Because the ones I have are very close together. And basically, you put it on and you can reverse your stimulus back and forth through it. I don't know if it's more specific for, peripheral nerve surgery. Like I'm fine with just using hook bipolars, but that's what it's for. Mostly for peripheral nerve stuff. Any other questions? All right.